My name is Dr. Brian Quinn, and I have worked as a pathologist at Baptist Health since 1995. I am board certified in anatomic pathology, clinical pathology, and transfusion medicine, and a medical director of the blood bank at Baptist Little Rock. I've also been actively involved in the blood management program here at Baptist. Earlier this year, Baptist Health Physician Partners established a multidisciplinary committee to oversee a system-wide blood utilization quality project, and we hope that this project will contribute to improved care and better outcomes for the patients that we serve. As part of this project, I have put together a series of presentations that are intended to update clinicians regarding the benefits of a conservative approach to blood transfusion. Although blood transfusions can be life-saving, they may also be associated with adverse outcomes, some of which are well known, while others may be less well recognized by both healthcare providers and patients. This presentation, which will last approximately 10 minutes, will review the potential adverse consequences of blood transfusion and will include recent estimates for some of these risks. The perceived benefits relative to the known risks of a blood transfusion are, of course, important elements when deciding whether or not to transfuse blood, and are also relevant in discussions with patients about informed consent. Looking at the benefit-to-risk ratio with respect to the transfusion of red cells, the decision to transfuse must be based upon a clinical assessment of the patient that weighs the risks associated with transfusion against the risks of anemia and the anticipated benefit of the transfusion. Of course, medical professionals are familiar with the concept that the therapeutic goal of a red cell transfusion is to improve oxygen delivery according to the physiologic needs of the recipient. However, there is increasing evidence that red blood cell transfusion in particular may be associated with a variety of adverse immunologic and infectious consequences. This discussion will focus on the risk side of the benefit-to-risk ratio for blood transfusion. The recognition of non-A, non-B hepatitis as one of the most common complications in transfused patients undergoing cardiac surgery and the advent of HIV in the 1980s changed the perception that blood donations from apparently healthy donors were safe. The infectious risks associated with transfusion highlighted the need to improve the safety of the blood supply. Donor screening, as well as serological and nucleic acid testing for a variety of viral infections, has led to a dramatic decrease in blood transfusion-associated viral infection. And the response by the blood bank community to emerging infectious agents has been relatively rapid. However, increasing evidence suggests that patients may suffer additional adverse clinical outcomes associated with blood transfusion. The circular of information published by the American Red Cross and other blood agencies categorizes transfusion-related complications into two broad categories: immunologic and non-immunologic. Immunologic complications of blood transfusion are listed and include transfusion reactions, transfusion-related acute lung injury, or TRALI, alloimmunization to donor antigens with subsequent formation of antibodies, and transfusion-related immune modulation, also known as TRIM. TRALI is characterized by the acute onset of hypoxemia and non-cardiogenic pulmonary edema occurring within 6 hours of a transfusion in the absence of other causes of acute lung injury or circulatory overload. The exact mechanism of TRIM is unknown, but it is postulated to be caused by the introduction of a variety of foreign antigens in stored allogeneic blood that invoke a number of immunologic changes, such as downregulation of cellular immunity and pro-inflammatory effects that increase the risk of secondary infections. The TRIM effect is thought to contribute to the observed increased incidence of infections in transfusion recipients, including hospital-associated infections such as pneumonia, sepsis, and postoperative infections. Although the TRIM effect is not universally accepted, many authorities believe that the concept of TRIM is bolstered by the evidence, such as the dose-response relationship of the adverse immunologic consequences as well as the fact that TRIM appears to be lessened by the use of autologous blood. In fact, a study that was recently published in JAMA provides additional evidence in support of the TRIM concept. Rode and colleagues reported results of a meta-analysis evaluating the association between a liberal transfusion strategy versus a restrictive strategy and the risk of hospital-acquired infections. This investigation encompassed 18 randomized controlled trials that compared these transfusion strategies among 7,593 patients. In this meta-analysis, the absolute rates of hospital-associated infections were 11.8% in the restrictive group and 16.9% in the liberally transfused group. The authors concluded that the implementation of restrictive transfusion strategies may have the potential to lower the incidence of hospital-acquired infection. In their statistical analysis, the authors concluded that for every 1,000 patients in which red cell transfusion is under consideration, 26 could potentially be spared an infection if restrictive transfusion strategies were used. The non-immunologic hazards of blood transfusion are listed next and include the direct transmission of infectious agents such as viruses, parasites, and bacteria, and transfusion-associated circulatory overload, or TACO. The risk of hypothermia and metabolic complications is greater when large volume transfusions are given. Finally, there are potential unknown risks, including the transmission of yet-to-be-discovered blood-borne pathogens that may occur. The next slide illustrates recent estimates of infectious disease transmission, which are provided by United Blood Services. As mentioned earlier, the risk of transmission of known viral agents has decreased significantly since the 1980s and 1990s due to the increasingly sophisticated nature of testing for these viruses, including hepatitis B, hepatitis C, and HIV, which have an estimated risk of only 1 in 1 million to 1 in 2 million blood units transfused. There have only been a handful of cases of transfusion-transmitted West Nile virus and parvovirus. Platelet components, which are stored at room temperature, have been implicated most frequently in transfusion-related bacterial sepsis. Although platelet pheresis products are tested for bacteria by the Red Cross prior to distribution, this does not completely eliminate this risk, with bacterial transmission estimated to occur once in every 5,000 platelet transfusions. Both gram-positive and gram-negative organisms have been identified as causing septic transfusion reactions. Bacterial organisms capable of multiplying at low temperatures, such as Yersinia, and those using citrate as a nutrient, are most often associated with red cell products, but this is estimated to occur only once per every 500,000 transfusions. Transmission of malaria by blood transfusion is very rare, and current CDC estimates place the risk of malaria transmission at much less than 1 per million, as estimated on the slide by United Blood Services. Babesia macroti is more frequently transmitted via blood transfusion in this country. This parasite infects red cells and is typically transmitted by tick bites. The disease is endemic primarily in the Northeast and Upper Midwest. Approximately 162 cases of transfusion-transmitted babesiosis, including 12 deaths, have been reported in the U.S., most of which have occurred in the endemic regions. Unfortunately, donors infected with this microorganism can be asymptomatic, which can contribute to transfusion-transmitted disease, and this tends to be seen mainly in the immunosuppressed patient population. The estimated incidence of non-infectious complications of blood transfusion is listed in the next table, including the risks of the various types of transfusion reactions. Transfusion-associated circulatory overload, or TACO, occurs relatively frequently and is, of course, a particular risk for individuals with underlying cardiac or renal disease, the very young, and the elderly, as well as in some patients with chronic severe anemia in whom a low red cell mass is associated with a higher plasma volume. The risk of TRALI is approximately 8 per 100,000 units transfused. TRALI is responsible for the highest percentage, approximately 40%, of reported transfusion-related fatalities, followed by hemolytic transfusion reactions. Although various stimuli in blood components may cause TRALI, it is thought to be most commonly due to HLA antibodies from donors sensitized during pregnancy or by prior transfusions, as well as the presence of pro-inflammatory molecules that accumulate in stored blood components. These stimuli may act together to trigger an inflammatory response, granulocyte activation, and injury to the alveolar capillary membrane with the subsequent development of pulmonary edema. The preferential use of plasma collected from male donors has been associated with a significant reduction in the number of reported TRALI cases, and this has prompted the AABB to introduce a new standard requiring that plasma for allogeneic blood transfusions be obtained from males, females who have never been pregnant, or females who have been tested since their most recent pregnancy and found to be negative for HLA antibodies. So in light of the known risks, the potential for unknown risks, and the often poorly quantifiable benefits of blood transfusion, blood use and transfusion outcomes are under renewed scrutiny. Consequently, a conservative approach to blood transfusion is being advocated by an increasing number of physician groups.